For Dr. Fabien Maldonado, he's Assistant Professor of Medicine at Vanderbilt University Medical Center. He is an internationally renowned interventional pulmonologist and going to discuss his experience in the research utilizing new approaches to diagnosis and the potential role for cryobiopsy. Thank you very much.
Well, thank you very much, and thank you very much for the kind invitation. So I'm another black sheep in that I am not an ILD expert per se. I'm not really part of the ILD Vanderbilt experience, but I'm an interventional pulmonologist, and so I'm in the business of doing biopsies, so I'm kind of routing against the previous technologies that you heard about. Although, as a disclaimer, I do think that how many of you have heard of cryobiopsies for ILD? Lots of people, great. How many of you have sent patients for cryobiopsies? How about surgical lung biopsies? All right, so a little bit more. So let's try to change that in the next 15 minutes or so. I'm going to try to change your opinion. But I will tell you that among all the procedures we do, this is one procedure we don't like to do. And we don't like to do it because it's fraught with difficulties and potential complications. And you've heard about the reports in the literature in the recent past. A lot of this has to do with the lack of standardization and the lack of uniform practices, and we're trying to change that. What do I do? Okay, perfect. So here are my disclosures. This is how Jürgen Hetzel, my good friend Jürgen Hetzel from Germany, who invented the Cryoprobes, came up with the idea. Thought how good it would be to get a piece of that tongue and look at it under the microscope. But here are my disclosures, primarily interested in lung cancer and pleural diseases. But here are the contentions I'd like to defend in the next 15 minutes or so. First of all, from an outsider perspective, and things are always constantly evolving in the field of ILD, but the classification of ILD is still primarily based on histology, and a lot of the talks you've heard already suggest that perhaps the high-res CT will have an increasingly important role, but clearly histology remains important. I'll show you the data for this. An accurate diagnosis of ILD is critically important. Obviously, there's a lot of development in technology, but also in therapeutics, and so it is more important today to make an early diagnosis of IPF than it was perhaps 10 years ago. I'd like to make the case that surgical lung biopsies are in fact underutilized, and whether that's justified or not, we'll talk about that. Conventional bronchoscopic techniques, and by that I mean forceps, conventional forceps biopsies, are essentially useless. Not completely useless, but not that great. And cryobiopsies, as far as we can tell right now, appear relatively safe and effective. And when I say relatively, it's relative to what we should compare cryobiopsies to, which is surgical lung biopsies and not to BAL or forceps biopsies. From an outsider, this is a little bit what we understand the process of the ILD expert to be. And so we send the patient to the ILD expert, and they go through a number of investigations. They kind of roll the wheel here and come up with some acronym which may or may not have any relevance to the patient, but in fact they do. And the reason for these complicated acronyms, of course, is primarily because of the fact that this classification was originally based on histology. So Avery Lebo, the pathologist who first described fibrotic lung diseases, looked at the slides and put them in different baskets, and UIP, which is usual interstitial pneumonia, came more frequently, so it became UIP, and that's really the rationale for the title. But we've moved from a primarily histology-based classification to this so-called multidisciplinary discussion, which currently is considered not quite the gold standard, maybe the silver standard for diagnosis of ILD. Silver standard because there's no gold standard. It's just a gathering of the minds and the Council of Elrond, and they pontificate and then come up with an answer. And this is a seminal paper from Kevin Flaherty showing that as you get more information, as you get more people talking together, radiology, pathology, clinicians, you get more confidence in the diagnosis and also more agreement on the diagnosis. But what's interesting when you look at this paper is that this degree of inter-observer agreement and confidence in the diagnosis only happens when you introduce the data from the surgical lung biopsy. So there's a big bump there. And in fact, histopathologic information has still the greatest impact on the final diagnosis. Now, this is importing surgical lung biopsy data as opposed to bronchoscopy data, and the reason for this, we already talked about this, but IPF, UIP is a heterogeneous disease. You're not going to have the same findings in different parts of the lungs. You need a fairly large biopsy specimen. You need a kind of a 10,000-foot view of the lung and see these alternating areas of very destroyed lung and some more normal lung. And there's certain features that you don't want to see, like some inflammation or granulomas and such things like that. So that's the rationale for surgical lung biopsy. Now, surgical lung biopsies are still, in spite of the great progress we've made in imaging, a fairly frequent intervention in the diagnosis of ILD. We do about 12,000 surgical lung biopsies every year in the US for the diagnosis of ILD. That's a lot of surgical lung biopsies. Here's data from the ASCEND and IMPULSIS 1 and 2 trials, the pirfenidone and nintedanib trials, and you had about 20 to 30% of patients who had surgical lung biopsies. So there's still something that is currently done. Now we know that the diagnosis of ILD is increasingly being made, and I think that's primarily due to the fact that we're doing a lot more chest CTs than we used to. It's difficult not to get a chest CT these days if you end up in the ER for ingrown toenail or something like that. But we did about 3 million CT scans, all CT scans in the 1980s per year in the US. We do 20 million chest CTs per year in the United States now. So clearly we're picking up a lot more abnormalities, but the rate of surgical lung biopsy has remained pretty much flat. It's about 12,000 a year. So it hasn't increased. In fact, the surgical lung biopsy done for the diagnosis of suspected IPF, which would be arguably the most important indication for surgical lung biopsy, has decreased. Right about 2000 to 2001, coincidentally, this corresponds to the era of increasing recognition that the high-res CT is actually sufficient in about half of the case of UIP to make the diagnosis. But it also has to do with this paper from my former colleagues at Mayo, who in 2001 looked at the outcomes of patients at 30 days after surgical lung biopsies, patients that all had a final diagnosis of usual interstitial pneumonia. And they found that out of these 60 patients, 10 of them died within 30 days. And just let that sink in a little bit, because that created a lot of controversy. A lot of people said, well, what kind of surgeons do you have at Mayo Clinic? Well, we got great thoracic surgeons. In fact, it takes a lot of courage to put papers like this in the press, and the reason why you don't see papers like this is because nobody publishes their bad results, and we get the same problem with cryobiopsies today. You don't hear about the case series of 15 cryobiopsies where 5 patients died, and that's a big, big problem. So for those of you that are well learned in statistics, that's a number needed to kill of 6. All right, so for 6 patients sent to surgical lung biopsy, 1's going to die from the surgical lung biopsy, at least after the surgical lung biopsy within 30 days. That's a huge number, obviously. Now, have things changed? Well, look at the best data we have. This is based on millions of inpatient stays between 2000 and 2011. And these are all comers with surgical lung biopsies for ILDs. And the mortality rate for patients that are stable at the moment of the biopsy is 1.7%, 30-day mortality. So 1 in 50 to 1 in 60 patients will die within 30 days of surgical lung biopsy. Now, if you happen to be one of these patients that are so-called non-elective, that are gradually worsening in the previous months before the biopsy, then we're talking about a 16% mortality rate. That's a huge mortality rate. And I would submit to you that it's probably something that we need to think long and hard about. Tom Colby, who's a pathologist from Mayo Scotsdale, pointed out to me that this represents 10,000 deaths from surgical lung biopsy during the study period, from 2000 to 2011. I mean, I don't know of any other procedures that would not get a black mark from the FDA with these kinds of numbers. Now, in terms of forceps biopsy, we obviously need an alternative, I think, to surgical lung biopsy. We'll feel very comfortable saying that. Whether it's going to come from imaging is a good question, certainly routing for this. But in terms of bronchoscopy, should we do forceps biopsies? And the answer is, maybe. If you look at retrospective studies where pathologists knew that they had the diagnosis of UIP on some of these slides, they were able to pick up about 20 to 30% of these diagnoses. But that's knowing retrospectively, in hindsight, that you're probably going to find them. If you look at all comers, and this is from Michigan, this was published last year, the value of forceps biopsies for ILD in general is about 20%, so it's not very good. And again, you got to be careful to compare apples to apples. You know, diagnostic yield is different for the expert team at the University of Michigan than it is for a community hospital, for instance, where you're going to get, yeah, it looks like fibrosis, but that's not what you want. You want UIP versus NSIP versus something else. So we need a better tool. So the ideal diagnostic tool in ILD would be something that would be minimally invasive, imaging-based if possible, but in the meantime, perhaps something that we can do with the flexible bronchoscope. We need large biopsy specimens for the reasons that I mentioned, and if possible, multiple biopsies from different lobes, because we know there's heterogeneity in the way UIP presents. A very important thing is that forceps biopsy are not only small, but they're also kind of crushed. You kind of pinch that lung tissue, and when you look at it under the microscope, it's all kind of collapsed, and it's very difficult sometimes for the pathologist to know what they're looking at. And we'd like, if possible, to have a safety profile that is similar to that of conventional bronchoscopies. So here comes the Cryoprobe. Cryoprobe was invented actually for neurosurgical applications. What they wanted to do is kind of freeze some areas of the brain and see what would happen when they would resect them. The principle is that you have compressed gas that goes into an inner cannula that gets released at the tip of the probe, and that rapid gas expansion freezes the tip to about minus 70 to minus 90 degrees Celsius, so very, very cold. And essentially what we do with cryobiopsy is that we freeze that tissue and just essentially pluck it out and hope that nothing happens. Sometimes we get bleeding, sometimes we don't, and that's been the issue. Here are how flexible cryoprobes look like. They're 1.9 millimeter in diameter. There's a 2.4 millimeter that gives you bigger biopsies. We tend to use the 1.9 because it goes through the working channel of the therapeutic scope without friction. So we know when we touch the pleura and we can pull a little bit and we know we're away from the pleura. We still get a fair amount of pneumothoraces, as I will point out to you. I'm going to just play some sequences of a video. Maybe we can start the video at 1 minute. And so, let's do that again. I did that, I'm sorry. Okay, so here's my former fellow, Rob Lenz, who's on staff now. So we're getting prepared to do a cryobiopsy. Now, when we do cryobiopsy, it's really important to understand that the main risk is the bleeding. Pneumothorax, we don't really care as pulmonologists. We know how to deal with this. And in fact, surgeons get 100% pneumothorax when they do a surgical lung biopsy. So that's not a problem. But the problem is the bleeding, and we can get in trouble. So in order to mitigate that risk, we always use a cuffed endotracheal tube. That's absolutely mandatory. If you're not going to use that, you need to use a rigid bronchoscope that you can use for a large suction channel and deal with the bleeding. So we load the endotracheal tube over the scope. We typically use this reinforced wire spiral tube. And very importantly, we put this bronchial blocker. And the way we do this is we attach it to the tip of the scope. I don't know if you've seen these blockers. They're called ARNT endobronchial blockers. They use them sometimes for selective lung deflation during surgery. The idea here is that we want this blocker to be outside of the endotracheal tube so that it won't impede the passage of the bronchoscope, but at the same time, we want it to be in the airway, ready to be deployed in case of trouble. So this is how we do it. We can go to the 3-minute mark at this point. Or not. No. If you're having trouble, we can skip that part. It's kind of the most fun part of my talk, so here. Can we go to 3 minutes? We can't. Okay, no problem. Well, you won't see it. So, but basically, I'll describe it for you. I'll show you. I'll draw a picture on the board. Essentially, we go down with a scope, and we deploy the bronchial blocker in the segment where we're going to take this biopsy. And then we pull the scope back to the trachea and intubate the patient over the scope. We fix everything together, and then we're ready to do a cryobiopsy. We go down with the scope and the cryoprobe. We always use fluoroscopy. People that have gotten in trouble doing cryobiopsies typically have not used the fluoroscopy. That gives you a sense of where you are with respect to the pleura. And that's important for two things. First of all, if you're on the pleura, you will get a pneumothorax. Now, my good friend Venerino Pelletti, who's done 800 cryobiopsies in Italy and published probably the most on the topic, likes to get pleura. He's a pathologist and an interventional pulmonologist, and he wants to see pleura to make the diagnosis of connective tissue disease-related ILD, showing pleuritis. So he gets a very high pneumothorax rate. Interestingly, only 30%, not 100%. But the other thing is that the further you are from the pleura, the higher the risk of bleeding. So if you're 2-3 centimeters from the pleura, then you get large bronchial arteries, and this is what really can get you in trouble. So you really want to be within 1 to 1.5 centimeters of the pleura. Then we pull everything together. The reason we're doing all this is because the biopsies are big enough not to go through the working channel of the scope. We can't stay wedged, and here's the problem. You pull the scope and the biopsy together, and then you're trying to thaw your specimen to collect your specimen, and meanwhile you have no idea what's going on in the patient's airway. It could be bleeding, hundreds of cc's of blood, and that's the big problem. I think that's been the major issue. So having a broncho blocker there, once we've pulled the bronchoscope, we inflate the blocker, and the bleeding, if it happens, is completely contained. There's no problem. Typically, we start the procedure by inflating that blocker for a couple of minutes and see if the patient can tolerate having that part of the lung staying occluded for some time. So here are some of the, just to give you an idea of the publications. So the first report on this technique was in 2009 by Jürgen Hetzel and his group, and then we've been getting a lot more publications over time. We're probably about twice as many as this right now in 2017 already. We've reviewed the literature. It's really important to understand that statistics can be quite misleading, but these are the published data on cryobiopsy, 31 studies, about 1,500 individual patients with a diagnostic yield for interstitial lung disease of about 75%. The problem, of course, is that statistics are misleading. It's very different to know what the diagnostic yield is at Vanderbilt than it is in the community hospital. You can have pulmonary fibrosis, normal lung, and that will be counted as a good diagnosis. Obviously, this is, again, not what we're interested in. We want a specific diagnosis of UIP. Now, the best data we have is this paper, again, from Pelletti and his group in Italy. And what they did is essentially try to replicate that study that I showed you earlier, the Flaherty paper, when they looked at the increasing diagnostic confidence and inter-observer agreement after sequential introduction of new information. So this is a very well-designed study, and what they showed is that the more information you get, the better confidence in the diagnosis, and in fact, it did not make a difference between whether you used cryobiopsy or surgical lung biopsy, which is a very compelling, I think, argument in favor of cryobiopsies. Now, this is a slide I stole from Tom Colby, who's probably reviewed thousands of these. He's very likely to be the most experienced pathologist looking at cryobiopsies for ILD. And he feels very, very comfortable calling usual interstitial pneumonia on the basis of a cryobiopsy. So here's a wedge biopsy, and this is about a 5-millimeter diameter cryobiopsies. And when you move this circle all around this wedge biopsy, there really isn't any area where you would not be able to call UIP, so I am told. Here are the fairly average sizes of cryobiopsies. This is from our experience here at Vanderbilt. And you can see that the vast majority kind of fall between the 5, 6, 7 millimeter diameter, again, a diameter that is deemed to be sufficient for the diagnosis. There's biopsies about 2 centimeters. There were one at 3 centimeters. I would have loved to have a picture to show you of this because it's hard to believe, but I do have a 2-centimeter cryobiopsy here. It looks like a little brain. It's beautiful. But we try not to get that much tissue, okay? We don't need all this. So we're very happy with the 5-millimeter biopsy, but just to give you a sense of the type of biopsies that we can get. This paper came out last year, and this had put a lot of cold water, I think, on the practice of cryobiopsies in general. This was the experience at Penn in Philly. They shut down the program, the cryobiopsy program, after this initial experience in 25 patients. And the reason for this is that they had fairly massive bleeds, including one that a patient that almost didn't make it, but did, thankfully. But they had some pneumothoraces. And so compared to the usual flexible bronchoscopy procedure that you do, this is, again, a procedure that is fraught with difficulties, and you're going to have complications, and you need to do things right. Now, there's a lot of things that were not quite right in this initial experience, but that's unfortunately what happens when we introduce a new technique in the interventional pulmonary field. There's a lot of different attempts, different trials, and a variety of techniques until people realized that the best way to do it is with a blocker and an endotracheal tube. But this was certainly a catalyst for us to look at our complications and to come up with some recommendations. Again, complications from our systematic review that we just submitted recently, we get about in general, 10% pneumothoraces. Again, the pneumothorax rate is not so much of an issue as the bleeding. The problem with the reporting complication rates is the same as reporting diagnostic yield. Everybody reports things differently. What is a moderate bleed in one institution is different than what it is in a different institution. Whether you get a blocker or not makes all the difference. You can have a massive bleed with a broncho blocker and still be fine. The patient will do well. But if you don't, a small bleed may become a problem. So you got to take all these things into consideration and again try to compare apples to apples. And I think the comparative technique that we should compare cryobiopsies to is surgical lung biopsy and move away from this idea that we should compare this to transbronchial biopsies, which are essentially useless for the diagnosis of ILD. Now, I'm chairing a expert panel with the ACCP, that's the American College of Chest Physicians, and we're trying to come up with somewhat evidence-based recommendations for the cryobiopsies. Now, we initiated this process literally 2 years ago, and it's not gone very far. We've had 2 meetings already this year, and we came up with the PICO questions. That's pretty much where we're at right now. We've got a very optimistic schedule with the publication at the end of next year. It's not going to happen, and so in the meantime, we convene a European-style lab meeting at the transbronchial cryobiopsy meeting, which happens every year in Italy, which is a great meeting. So here's Jürgen Hetzel, Tom Colby, Sarah Tomasetti, who's part of the Poletti group in Italy, Oren Frichter, Jeru, I believe is here. And so we came up with this working group last year, and we just got this paper accepted for publication that should be out in the next few months, and we make a certain number of recommendations, which are here. You can take a picture of this if you're doing cryobiopsy at your institution. That's how you should be doing it for the meantime until we come up with more definitive recommendations. And that is it. Thank you very much.